Okay, week 2, restrictive lung diseases. Okay, so restrictive lung diseases are going to be, there's a difference between restrictive and obstructive. Obstructive would be like what we had last week with, I guess at this point it wouldn't be last week, week 1, where we had things like emphysema, COPD, asthma, cystic fibrosis, issues with getting air into the lungs. The lungs have something that obstructs the ability of getting air into it. Restrictive is going to be more something that prevents the lung from being able to have full expansion, meaning we're not going to have as much in the way of lung volume. So things that affect the rib cage, for example, if someone has trauma to the rib cage and they break some ribs, there's going to be an issue with the lung fully expanding, and it's going to restrict how much the chest can expand. And so when it comes to restrictive issues, we can have issues that are either based on pulmonary function or they're based on the pulmonary function, like involving the parenchyma or the pleura themselves, or we can have issues with the actual chest wall or with sending signals to the chest wall and the musculature involved with the chest wall in how they function, which you'll get to that in a bit. This is still kind of stuff that we had from week 1, same kind of stuff. I'm trying to go through and make sure these things are a little bit faster for you guys. So when it comes to actual diseases of the parenchyma, such as with it outside the bronchi or the alveoli, we first have fibrotic interstitial lung disease. When I looked it up, this was more often called simply interstitial lung disease. And the overall definition was that they are diseases that affect the interstitial spaces, including alveolar epithelium, pulmonary capillary endothelium, basement membranes, the perivascular spaces or tissue, and I think I may have missed a letter, perilymphatic tissues. What happens is that it promotes increased scarring, thickening, inflammation, or edema accumulation in these interstitial spaces. So this is supposed to be a normal alveoli, and this is our normal blood vessel, with interstitial lung diseases, which normally end up with fibrosis and scarring on the outside, in the interstitial spaces outside and between the alveoli. We would have some form of inflammation occurring, leading to scarring and having impediments to our ability to have gas exchange between the alveoli and the capillary. There are supposedly 4 main types. I looked around and I saw that there were a number of different systems of classification. So there, according to this, are like 4 major types of interstitial lung disease. When I looked it up, it said that there were kind of a number of different ways that we could classify interstitial lung disease, and most of the time it is just interstitial lung disease. Other ways that we can include or classify them is, well, other ones that seem to be common were interstitial lung disease that came from inhaled substances like asbestosis or asbestos, drug-induced like with antibiotics, autoimmune diseases like with lupus, infection through tuberculosis. It could be idiopathic, which could be idiopathic pulmonary fibrosis or sarcoidosis, and it could be from malignancy. So as you can see here, this is a lung that came from a person that suffered from interstitial lung disease. We've got a lot of fibrosis in here. I hope the green is just a dye to better show what everything is in here versus being perhaps a fungal infection. But a fungal infection like asbestosis or aspergillosis would have this kind of, or would be a fungal infection, so this wouldn't be outside the realm of possibilities. Come on. Oh, what the heck. Okay, case study. So the whole idea here is that there are different ways we can classify interstitial lung disease. A lot of it has to do with simply exposure to different things or having a poor type of response. And the treatment is similar for all the different types of interstitial lung disease, of which there are like 180. If they smoke, tell them to stop. If they, for example, work with HVAC systems or crawl under houses to do a lot of work there and they're exposed to a lot of different types of fungi, then tell them to either knock it off, find a different job, which of course is super easy, or tell them maybe to start using a respirator or something. They may be put on anti-inflammatory agents and immunosuppressive agents. If it gets really bad, they may have to have oxygen on a regular basis, and then lung transplant if it's really, really bad. There was a person I knew who had aspergillosis from black mold, working as an HVAC system technician, and developed COPD, severe COPD, at like the age of 40 something, and had to either get a lung transplant or go on to hospice, basically. So ARDS is a very severe syndrome, acute or adult respiratory distress syndrome. It normally comes from some other form of pathophysiologic process. There are actually a lot of cases per year, and the mortality rate is very high, 30 to 63. The most common etiology is going to be sepsis, though severe trauma is very common, as is gastric acid aspiration. A person who is intubated has a risk of developing ARDS because they can't control their airway because they're intubated. The ventilations also knock out some of the protective mechanisms they have, and so they can either aspirate gastric acid or even just simply their oropharyngeal secretions. Fat emboli and shock are possible etiologies for ARDS as well. Don't really quite remember what fat emboli had to do with it, but I remember something about trauma leading to the potential of a fat emboli floating around causing this. I don't remember exactly. I don't remember it being that important anyway. Basically, with the pathogenesis, we had injury, which led to an increase in the pulmonary vascular permeability because of the inflammatory response, the immune response to that area. For example, like we had gastric acid secretion, we would have an immune response to that. And so all of that is going to lead to an increase in fluid within the alveolar space, and it's going to make it so that O2 transport, respiration, gas exchange is going to become less effective. We're also going to develop this proteinaceous fluid that fills inside the alveoli and in the interstitium between the alveoli itself, leading to pulmonary edema. That pulmonary edema is going to further the inflammatory response because we're going to have the alveoli, the very delicate tissues inside the lungs are going to have inflammatory response themselves from just simply the fluid. That's going to create even more fluid. It's sort of this compounding effect where every single motion as it goes up becomes more inflammatory or inflamed, which creates more fluid, more, over and over. All of that overall within the alveoli is going to cause this fibrous hyaline cartilage. And this fibrous hyaline cartilage is going to decrease the compliance of the alveoli, each individual alveoli, and thus the lungs as a whole, because normally on, for example, this side, this nice thin surfactant layer helps to allow the alveoli to expand and contract as we take a breath. This hyaline cartilage, though, doesn't do a dang good job at all of allowing for the alveoli to expand at all. So you get a lot more kind of trapped air and minimal expansion and contraction. And that's partially because a lot of this surfactant ends up getting destroyed from maybe perhaps whatever the original insult was, and then as well the immune and inflammatory response afterwards. And so a lack of surfactant leads to a lot of the lack of lung compliance after having that fibrous hyaline membrane created. We're going to see a lot of alveoli collapse, forming atelectasis, and then we're going to see this diffuse fluffy alveolar infiltrates, such as down here, this looks like the normal pair of lungs here, whereas on this side we've got a lot of this sort of junky white infiltrate here that looks like fluffiness. So we have that diffuse, fluffy alveolar infiltrates. And because of the fact that we have such poor gas exchange, we're going to have severe hypoxemia. And yeah, let's see here. So we also have down here, we have sort of a gap formation that occurs between the capillary and the alveoli, which also further reduces the capabilities of gas exchange. So with ARDS, which is always a very severe emergency, we need to respond to this as quickly as possible, there is some form of precipitating event. For example, a patient was involved in a vehicle crash, a motor vehicle crash, collision. Or perhaps they had a crush injury to their leg, or perhaps they had pneumonia, led to sepsis, or some other kind of an infection led to sepsis, or they had a head injury that led to them being intubated or something, and went to the ICU and got an infection through the lungs that way. Whichever way, whichever etiology it is, we then have a sudden marked respiratory distress. Suddenly, they are like, I cannot breathe. They may be unconscious, in which case they won't say that, but you'll see that they're having very difficulty breathing, and their vital signs are going to shot, and you'll notice. We need to act very quickly on that. They may show dyspnea, tachypnea, decreased O2. The hallmark signs of this is that they are hypoxemic, so their SaO2 is going to be very low, their PaO2 is going to be very low, they're probably going to have CO2 levels that are very high, and they are going to be refractory to supplemental O2, which means they are not going to respond well to extra O2 because it's not a matter of just simply getting more oxygen on them. They have to have someone else take over ventilations for them, more than likely, because their alveoli are pretty much collapsing. And if aggressive treatment is not taken, they have a high risk of dying. And if we do a chest x-ray, we're going to see that they're going to quickly convert from this sort of normal pair of lungs to this super white, fluffy alveolar infiltrate and white out throughout the lungs, which is a really scary thing to see. ERDS, or infant respiratory distress syndromes, very, very similar to ARDS. Typically, this is going to be due to a premature infant, so under 30 weeks, who is not treated with steroids. So in infants that are that young, typically they lack surfactant on their own. And so nurses, doctors are meant to give them steroids to promote surfactant development in the lungs. If they are not treated adequately with steroids, then they may develop ERDS. Most of the time, the most common reason for why they develop ERDS. It's also known as the hyaline membrane disease. For these kids, a little bit differently, they have hemorrhagic pulmonary edema. So both ERDS and ARDS have that pulmonary edema that builds up. In adults, normally it's proteinaceous. So a lot of proteins which come out from the blood vessels, whereas in ERDS, they develop more hemorrhagic pulmonary edema. They're still going to have that patchy atelectasis and the hyaline membranes, as well as a hypoxemia that is refractory or non-responsive to supplemental O2. The supplemental O2 may work if we use ventilation and supplemental O2, but just simply putting O2 on them is not going to do anything because most of the time they're having alveoli that are collapsing, and a collapsed alveoli that has no air movement through it at all to begin with isn't going to have any benefit from an increase in O2. All right, so pneumonia, super common. This is a simple inflammatory reaction in alveoli and the interstitium itself that's caused by some kind of an infectious agent. Commonly, this is going to be from aspiration of oropharyngeal secretions, especially in, say, like older adults who, as we learned last time, or I guess in week 1, have a more difficult time with producing a strong cough reflex. So a lot of the musculature that's involved in being able to cough is weakened over time, and so they end up not being able to cough up quickly secretions that they might get accidentally swallowed into their lungs when they're eating or sleeping or any other time you might accidentally swallow some spit. They could also have it from direct inhalation of an organism or a chemical, or contamination from systemic circulation. Say there's an infection somewhere else that traveled then to the lungs. There are multiple different classifications of pneumonia. We can have community acquired, where literally it just came out from the person wherever they were living, or perhaps while living in an assisted living facility, where the close quarters promotes more potential for pneumonia acquisition. They can have hospital acquired, which would actually then, I believe, not be covered by insurance or Medicare, because of the fact that the hospital is responsible for it. Bacterial is more common, and bacterial is going to be the one that produces more of an expectorant or a productive sputum, whereas viral is not as likely to produce sputum of any kind. And then we can have some sort of a chemical pneumonia, though I don't actually know much about what a chemical pneumonia would look like compared to everything else. There's also ventilator. How does it classify? Ventilator-related or ventilator-associated pneumonia, VAP, I think it is, where those who are intubated and on a ventilator have a high risk of aspirating their own oropharyngeal secretions, leading to pneumonia, which then also could potentially lead to ARDS later on as well. So those who are high risk, the elderly, because they don't have as much of a cough and gag reflex. Those with a definitive diminished gag reflex, such as those who are intubated. Those who are seriously ill, perhaps too weak to cough up stuff, or are going to be creating an infection from somewhere else that travels to the lungs. Hospitalized patients, when nasty hospital workers don't remember to clean themselves thoroughly enough and then cross-contaminate patients. And just those in general who are immunocompromised, say HIV positive patients, are at higher risk. So we have, in general, we may or may not have a compromised pulmonary defense mechanism. Sometimes just simply exposure leads to pneumonia. But for a lot of people, it starts with a compromised pulmonary defense mechanism, and then some organism that leads to pneumonia enters the lung. That triggers a pulmonary inflammation. The inflammatory cells then invade the alveoli, which promotes inflammation and a lot of exudate. The alveoli then fill with the exudate fluid from the good, normal immune response. The organism that then had infested or invaded the lungs consolidates, making it very difficult for the immune system to attack, to kill the invader, and properly expectorate, especially if we're talking about someone, for example, who's older, who can't expectorate very easily because of weakened respiratory systems, respiratory muscles. So the severity depends on the age, the cause of the pneumonia, and any other comorbidities the person may have. They may have crackles, bronchial breath sounds over the affected area that sound kind of junky and coarse. They may have fever and chills and look originally sort of more of like a cold or a flu. They may have a cough that is productive or non-productive. And if it's bacterial, more than likely there will be a purulent sputum of some form. If it's viral, it may present as an upper respiratory disease, which is actually then a prodrome, meaning it is a sort of a sign. I think I had it said better. An early symptom that indicates the onset of a disease. So I'll say it again. An early symptom that indicates the onset of a disease. Whatever. Meaning that Originally, with a viral pneumonia, you might end up just looking like simply having a common cold, the flu, something like that, with more upper airway symptoms. But this manifestation, this presentation, is simply a prodrome. It is simply a sign of a future disease, which is, in this case, pneumonia. They also, with a viral pneumonia, will likely have a non-productive cough, since there's not as much to have to actually expectorate in trying to capture the bacteria that's in there, because it's not bacteria, it's viral. And they may also have more hoarseness. Most of the time when we're talking about someone with a viral pneumonia, it's more self-limiting and it's more supportive care rather than giving other medications. All right, so pulmonary tuberculosis is going to be actually it's a pretty decently common lung disorder or infection. People who are high risk are people who have had prior infections. They are always going to have a very high risk of reinfection. Those who are malnourished or immunosuppressed are not going to be able to fight off the infection from the very get-go. Those living in overcrowded conditions are going to be at high risk of simply being exposed, as are those who are incarcerated. Immigrants are going to be living in less secure, less clean conditions on a regular basis, and may also be living in more overcrowded conditions. And then the elderly may also be living potentially in more overcrowded conditions, such as in assisted living homes, and are also at high risk because they are not going to be as well nourished, and they may also be more immunosuppressed. So the etiology is always the Mycobacterium tuberculosis. And so we have the exposure to the mycobacteria, it gets into the lungs. Alveolar macrophages will then ingest the mycobacteria, at which point they'll either be destroyed or they will persist and multiply. Either way, the body is trying to destroy that mycobacteria. And I believe even if they are destroyed, the body still kind of thinks that they are not really fully destroyed. The mycobacteria, destroyed or persistent, will disseminate through blood and lymph throughout the entire body, but within the lungs, and that's how we actually will find it, is throughout the blood because we do that skin test or the quantiferon. But within the lungs, we're still going to have an immune response to the alive or dead tissues or microbes. The T cells and the macrophages will surround it, form these granulomas as sort of this protective mechanism to try to prevent it from infecting other parts of the lung. But they're never really fully able to get rid of it, or they're tricked into thinking that it's more active than it really is. And we develop these, where is it? Gone tubercles or cavernous lesions. So clinical manifestations is that they're going to have some sort of a history of contact with an infected person. They are going to have a chronic cough that could become, what is it? Hemoptysis, hemoptytic. They'll have potentially blood-stained sputum, sort of a classic sign. May become productive with just regular purulent sputum. They'll have fatigue, maybe extrapulmonary signs like afternoon fever, night sweats, weight loss. And then they are at risk for, why did that happen? They are at risk for reactivation if their immune system becomes suppressed. Diagnosis occurs from a sputum culture which is definitive. Unfortunately, it takes a while, and they can continue to kind of suffer and have problems until it's defined and they can start themselves on some antibiotics. And it requires 3 consecutive, that's important to remember, 3 consecutive morning specimens. Other diagnosis ideas or possibilities include a chest x-ray, quantiferon, or a TB test. The TB skin test, though, there's a potential that you can develop a false positive if you've been exposed to the TB vaccine, which I think is CGB or GCB or something that sounds like CBG. The quantiferon, though, will not give a false positive because it's a blood test. So just remember that the TB test can give a false positive if you've had the vaccine. A Goan tubercle is sort of this, I believe it builds off of that granuloma that develops. It's a calcified nodule, and it develops with a bunch of extra stuff in the lungs, whereas a cavernous lesion is sort of this wearing out of part of the lung from an immune response. So the immune response may present as or may have some slight autoimmune type reactions impacting parts of the lung that were healthy and normal to begin with. Treatment is very difficult. All cases are going to be reported to the health department and then to the CDC or the State Department. They're going to require a 9 to 12 month long multi-antibiotic regimen because of how difficult it is to treat tuberculosis. Many times, unfortunately, also there may be multi-drug resistant TBs that are infecting. And a lot of times we're going to want to have directly observed therapy because non-adherence is a very severe issue for tuberculosis because of just simply how long it takes. And if the patient is from, let's say, a low SES, where they need to simply move to wherever they can get access, or they don't have transportation capabilities to get to their doctor's appointments to maintain direct observation, then it becomes really difficult, and they may just kind of bounce off the bandwagon and say, it's okay, I'm healed enough. But then they get sick again and they give it to someone else. Okay, so now pleural space disorders. So the pleural space, normally we have the rib cage here, we have the lungs here. The outside of the lungs themselves are the varietal or visceral pleura, whereas the space here on basically the part of the rib cage itself is the pleural or the parietal pleura, and there's a little bit of like synovial fluid as lubricant between the two layers, and when the ribs expand by muscular contraction, there's like a vacuum seal because of that fluid in here between these two layers that pulls the lungs out, and then the lungs pull the rib cage back in via the elastic fibers. I think I actually have a good picture of that. Oh, wrong one. Elastic fibers that are around each individual alveoli. So when these expand, they stretch out these elastic fibers, and the elastic fibers then contract to cause the passive exhalation. And that's partially what helps close or pull the rib cage back in. So pneumothorax, something punctures the chest wall, either from the outside, or perhaps we can have a rib puncture from the inside. Something pops that vacuum space that's supposed to occur between the lungs and the rib cage. And the lung then, because of those elastic fibers, kind of recoils down into this small size. Depending on the pneumothorax, it doesn't always go down to that full size. It may be a very minor pneumothorax, but it can become that severe. So we can have either a primary or a secondary pneumothorax. With a primary, more often than not, that's called a spontaneous pneumothorax and occurs in tall, young, thin men. A lot of times they are basketball players, and maybe in the middle of the game, all of a sudden they pop a pneumo. We don't really know why. There's no real underlying disease going on, but if they smoke, that is an increased risk. Secondary is also very common, or not very common. Secondary is also a common form of pneumothorax. Comes from a pre-existing pulmonary disease or from a traumatic event, which can also lead to a tension pneumo. A tension pneumo is going to be a much more emergent issue. So say someone had a car accident, one of these ribs broke just enough to kind of puncture the vacuum space between the lungs and the rib cage. and now there's air coming in. But with the way that the rib happened to break and puncture the rib cage or the vacuum space, air can't get back out. It can just come in. So what happens is each time the person exhales, further and further air gets sucked in, because when we expand the chest, that creates negative pressure in here. As that negative pressure develops, we're going to suck more air into this space. As more air develops in this space, more pressure develops, pushing everything this direction. When we push over this direction too much, we're going to cause this mediastinal shift. That mediastinal or mediastinal shift is going to create pressure on the heart and on the lung, the other lung that's not affected, creating a whole host of problems. We're going to have a decrease in cardiac output. We're going to make breathing that much more severe. They may pass out and go into cardiac arrest from just simply not being able to have cardiac output or even lung oxygen transport in the lung at all. The definitive mechanism to fix that is going to be making a little tiny hole right there with a needle, letting the air out. So with a pneumothorax, if they are small, they're not usually detectable. They kind of develop a little more slowly. You start noticing, I'm having some trouble breathing that I shouldn't have. If they are large or a tension, they are completely emergency situations. People can die from them. You can also develop severe tachycardia because, of course, you're, one, fight or flight, and two, you're going to be trying to make up for the lack of oxygenation that's occurring from missing out on potentially up to one lung. You may have dyspnea, of course, hypotension from a lack of cardiac output, tracheal shift, decreased or absent breath sounds on the affected side, and then subcutaneous emphysema, which is this stuff right here. So this is someone's eyeballs, eyelids. Air has managed to travel up to the eyelids from sort of squeaking out from that vacuum space, and finding the nearest space that it can kind of accumulate outside of pressure. The chest is also an area that can develop subcutaneous emphysema. Literally, when you press on the chest, can kind of sound like Rice Krispies cracking. The treatment is going to be a chest tube. So they're going to put a chest tube in there on the side to drain out the air. In the emergency setting, like as a paramedic, might put in just simply like I showed up here, let's see here. So if it's on this side, we're going to do the second intercostal space, which would be probably right about there. Up there would not be because that's under the clavicle. And that's going to let out a whole bunch of air. Pleural effusion. This can also be called a hemothorax if the fluid is blood instead of water or non-blood. It's some kind of pathologic collection of fluid. It's resultant from another disease process, and the imbalance comes from more fluid accumulation than removal. Normally, we do have some form of fluid around the outside of the lung to help with lubrication as we expand and contract our rib cage, providing lubricant against the two rubbing layers, which provide the vacuum layer. The clinical manifestations depend a lot on the size and the cause of the effusion. If we're talking about something less than 300 mils, it may be completely asymptomatic. If we're talking about something that is a tremendous volume of fluid, they could die over time. I mean, it won't be necessarily immediately, but if they have a lot of comorbidities, if they were barely holding on because they had COPD and they were barely holding on to that respiratory drive and how much air they could actually move, a relatively minor pleural effusion could send them into respiratory arrest. They could have dyspnea and dry cough. Pleuritic pain, so if they have pleuritis or some kind of inflammation between the two layers along with fluid, or the fluid causes inflammation, then they may have that sharp pain that worsens with inspiration. and they may have decreased or absent breath sounds, because if this fills up all the way, then the lung will be collapsing from this extra pressure. Now, this is different than pulmonary edema. Pulmonary edema is inside the lungs, whereas this fluid occurs outside the lungs. So don't get yourself mixed up on pulmonary edema versus a pleural effusion. And then if it's a really big, massive effusion, then we may actually have full filling of the lung, like a pneumothorax, but with fluid instead, compressing the lung entirely and pushing it to the side, causing a tracheal shift. So similar to a pneumothorax, we're going to be using a needle into the chest to drain all that fluid out. And then we're going to treat the underlying cause of why they have this in the first place. If it's small, it won't be emergent, but if there is a mediastinal shift, it will be emergent, because that means there is a massive amount of fluid buildup inside here. And then the thoracentesis is what this is. If it's small, they may just actually let it try to sort of get removed by the body naturally. So extrapulmonary disorders come from issues with the chest wall, or with the neural impulses that are sent to the lungs to breathe via the muscular contractions. So as you can see here, this is a person that suffers from very severe scoliosis and kyphosis and lordosis, it looks like. And so their rib cage is not in a position like this to allow for full expansion and full exhalation. Nope, come on. So there are a number of neurological disorders that can affect a person's ability to breathe. I don't remember how much I had to know about these, but I know, or I would remember simply, that poliomyelitis is about the nerve cells themselves in the brainstem and the spinal cord, which are used to produce signals that go to the lungs and the musculature to tell them to breathe. ALS is about muscular weakness, as is muscular dystrophy. And then Guillain-Barré syndrome is about demyelination of the peripheral nerves. So the nerves don't send the signals as well to the respiratory system to breathe. And myasthenia gravis is similar to Guillain-Barré in that regard, in that the neuromuscular junction is compromised, and so they can't send the signals as well to the lungs to breathe. And then we could have actual chest wall deformities, like I said, scoliosis, kyphosis, lordosis. If they're severe, then they can lead to significant impacts on a person's ability to expand the chest wall. I guess females are affected more often than males. I didn't remember that. So if the lung volumes are compressed, it can lead to atelectasis and hypoxemia. The more the deformity, the more the respiratory compromise. And that's, yeah. And that looks horrible. It looks a little better. That's good. Oh, that's it. Okay.